I guess the most common long-term effect is the risk of gallstones.
That's been taken out.
Think about. Then the other ones are really the GI problems, I think, the bowel problems potentially, although a lot of people don't get that. I don't think there's any, we don't have a lot of detail about people who have been on it for years and years. Amanda might want to comment because some of the people with acromegaly are actually on these drugs for a long time, slightly different circumstance, but the same drug.
I mean, I don't think there's anything more than what you've said.
No.
Yeah. I don't think there's any other long-term side effects that I'm aware of, other than what David's already said.
I would say, and I'd be interested to hear from a dietitian as well, but we know that somatostatin analogues in a significant number of people cause fat malabsorption, and if you're not absorbing your fat, you're not absorbing your fat-soluble vitamins. So vitamin K is a fat-soluble vitamin, so that's just off the top of my head, but that would be the theory, my theory anyway. Hey, can I ask a question, because I've got the microphone, I can be cheeky. Jane, it was really interesting hearing you talk about the SSRI antidepressants, because this is a question that comes up in our patient community all the time, and today in our Facebook private discussion group there was a lively conversation about this very topic, and so while I've got the microphone, I'm interested to hear, particularly from our endocrinologist and David, if we've got someone who is suffering from depression. I've got patients who tell me, oh, well, my doctor told me I couldn't go on antidepressants because I've got NETs, and clearly that's not great. If you're depressed, you need treatment. But I'm interested, Amanda or David, or if someone's got carcinoid syndrome, so obviously they've got too much serotonin floating around, shouldn't they be happy because they've got so much serotonin floating around?
I was thinking exactly that.
Get James.
Yeah, I think you know that. I would say that I think it is worth trying an antidepressant in anyone. Obviously, different people are having side effects to different medications all of the time. I would suggest that you would try the medication if it worsens symptoms. Obviously, that's probably not the best medication for the patient. You could try a different medication. That would be my feeling, but I can't answer why everyone's not really happy when they've got too much serotonin.
Probably because they've got incapacitating diarrhoea and flushing and abdominal pain. So that has been, and certainly historically the thinking was, well, you shouldn't be using an SSRI with people with carcinoid. It certainly is counterintuitive. But I think the side effects you can get from that medication are particularly dry mouth but gastrointestinal. And I've had patients who haven't had a neuroendocrine tumour who've had incapacitating diarrhoea. It's impossible to predict that. We've got, I put up a slide to show we've got a lot of options. One of my more cynical patients referred to it as the Turner, Suckett or C therapy. I actually prefer to consider it as a robust clinical trial of response to medication.
So the first question, how long is in the body? There's two things, or two parts to the disappearance of the lutein. One is how your body handles it and excretes it, and so it goes through the bloodstream and then it gets excreted into the urine via the kidneys. And so that's the main method of excretion. And so within about 6 hours, about 70% of what you've been administered has actually already gone out into the toilet. So, and then there's a remaining 30%. And that will be circulated around, taken up into the tumours, and when it's taken up, it actually stays there. And then the main effect of clearance is just the radioactive decay, and the half-life is at 6.8 days, and so there's 50% left in after 6 days, and then 12 days, there's only 25% left. So, essentially, we think that within about 2 weeks, virtually everything's gone. But most of it is gone just in the first 6 hours. So a very rapid drop, and then there's some retention after that. The second question is about the nerve endings or other parts of the body that are affected. It's not really recognised as being a major issue in terms of affecting nerves at all from a clinical perspective that people would have noted. I mean, the main side effects that I've talked about are that it will, it is bathing, it's in the bloodstream, and that's continuous with the bone marrow. So the main thing that we look at a blood test to see that it hasn't reduced the blood counts, and of course there is that rare risk in a small proportion of people that can develop a problem, down the track. But overall, when we're weighing up who to treat and who not to treat, we're really guided by that clinical trial that shows, overall, the majority of patients benefit, but there is that risk for 1 or 2% of patients. Look, it's not really been recognised or picked up as being a cause of arthritis or arthralgia. But look, I guess we need to obviously monitor.
We've had another question that came through the forum to do with rheumatoid and osteoarthritis. Does lanreotide therapy have any association with rheumatoid or osteoarthritis?
I'm not aware of any association with rheumatoid, which is really an autoimmune disease. I guess it's always difficult because people are on those sort of drugs. It's a bit like a breast cancer patient on an oral hormonal treatment. You're on it for years, 5, 10 years. So if something happens immediately after starting it, it's probably a rare side effect. If it happens 5 years after you've been on the drug, sometimes it's very hard to know, well, is that just your general joint problems? Is it something else? Is it related to the drug? And I guess in the end, it's very hard to differentiate that, and sometimes you have to make a judgment, well, is this a real problem? If it's a real problem, then maybe you have a trial of something, but it's difficult if it's something that you think is controlling the tumour. We occasionally swap between the drugs. There's absolutely no evidence whether you're swapping from one to the other there's any different side effects, but occasionally people who have side effects, which are usually more gastrointestinal, you might go from one to the other to see if that is better tolerated.
Can I make a comment about that? I think it's really important to recognise how important your GP is. I know that they don't have the specialist knowledge to manage NET, but they do have the specialist knowledge to help you get a pap smear, have your blood pressure checked, to advise you about healthy weight, to support the input from the nutritionist, dietitian. You actually are allowed to have health problems that aren't related to your cancer diagnosis. As we get older, we're all facing the risk of heart disease, deteriorating bone health, and the news is that exercise is actually something we should all be doing. Mostly.
Another question that was on to do with heart. How often should I have a heart scan? I was told that lanreotide protected the heart better than somatostatin. What is your opinion?
Well, I guess the first question is why you're having a heart scan. And so what we're really trying to do is screen for carcinoid heart disease. And so carcinoid heart disease is thought to relate to serotonin and other things that are being produced. So if you don't have carcinoid syndrome, you shouldn't be getting carcinoid heart disease. So first thing is in that group of people, you don't need regular heart scans for carcinoid heart disease. So not everybody needs them. And then I think it's a bit controversial, but what's the best way of screening? If you've really got carcinoid syndrome, then being on the drug is possibly protective. We don't know that for sure. David may comment on that, but it's probably the best thing we can do. I think it's reasonable that people would have regular scans. Often that's maybe every 2 years if the scan is perfectly normal. But if you have an echo and the valve looks a bit funny, then you probably do it earlier. There are other tests, blood tests that we use for heart failure that have been used for screening for that, for carcinoid heart disease in other places, but I guess we haven't routinely done that. We do rely on echoes, and then it also is a little bit dependent on your echo service and having somebody who really, if there's a bit of a change, then maybe making sure that that's being looked at by a cardiologist and not by radiology group who does 1,000 echoes a week and maybe is not used to looking at carcinoid heart disease. So I think we've had a few patients with issues more recently, and we are being a bit more stringent in how you do it, but it is selecting the right people. And I think if you've had a scan and it's normal, or you don't have carcinoid heart disease, it's really not a major issue. We certainly can. I guess a multidisciplinary team is people with a knowledge of neuroendocrine tumours. So certainly in some other, a lot of the hospitals, some of the private hospitals will have a multidisciplinary group who discuss things. I guess what we have done, particularly in Australian centres, is we have most of the sites have a PRRT, offer PRRT, and we offer advice, but we don't need to manage every patient with a neuroendocrine tumour across the state. It's just not possible. So we have a very good relationship with practitioners both in the public and private sector, and when we did our survey, over half of our neuroendocrine patients we share care with other oncologists and surgeons up and down the coast, and often we will maybe discuss them once a year when they have their scans and provide advice back. We may or may not see them. So I think there's an opportunity to do that. Now, obviously it depends on your individual practitioner and having a discussion about them and how open they are. But the vast majority of our patients don't need to come and see us every time, but we may be able to provide useful input to people periodically.
Can I just ask a follow-up question about that? So if you're in, I don't want to pick a town because I don't want to name names, but if I'm in Timbuktu and I'm seeing Dr. Bloggs in Timbuktu, who's a generalist oncologist and he sees everybody with breast cancer, bowel cancer, and my single, like I'm his only net patient, and he's had me on butt jabs for years, and how would I know whether he's on the right track or whether he's talking to a multidisciplinary team, or whether I should be seen by a or have my case discussed by a multidisciplinary team, because Timbuktu is a long way away. How do I know if I'm having the right scans, or is it just that he rings me? I mean, I ring me. That's wrong. Anyway.
You do get a lot of phone calls. Look, I think it's really the relationship you have with your practitioners who are managing you, and I think that's both your GP. I'm going to conflict of interest, my wife's a GP, but you really need to talk to your GP and your oncologist, and you need to have these discussions, because we do get people who come down from a long way away for a second opinion. We need to come and see you. They've never discussed this with their GP or their oncologist, and their oncologist may be a pain in the ass, and maybe you want to go and find a different oncologist, but that oncologist may have already spoken to us about your condition. Hopefully they would have said that something to the patient, but maybe they haven't. I guess if things are, I think some of it is, if things are stable, if you've got an early stage tumour, you're on somatostatin analogues, and you're having some sort of scans, your symptoms are stable, your scans are stable, then probably things are fine. But if your tumour is progressing, then I think that certainly that's the time or something's happening. There's no doubt that there needs to be a broader discussion about what the best treatment option is. Now, whether that can happen in that local environment or not depends a bit on what's happening from the tumour point of view and what you think might be the next step. So if you need a surgeon or a gastroenterologist to do something, that might happen in one place. Clearly, if you need people consideration of PRRT, then you're going to come to see the nuclear medicine people. So I guess I'm not answering that correctly in the sense that there's no right answer, but I think it is a relationship thing. And you know, all of us who see patients all the time, we have some patients who, for whatever reason, don't gel with us, and they say, "Can I go and see my colleague?" And I think that's a reasonable right. But I think you need to discuss it with your GP and your managing practitioner first, and hopefully they'll be helpful in trying to facilitate that. I'm not aware of any trials particularly in stem cell therapy and neuroendocrine tumours. Certainly at sort of international meetings, I haven't heard anything. It may be that people who are trying that might occasionally include a neuroendocrine tumour in their early phase study. I guess the one thing that is being talked about is CAR T cells, which is another thing that's been out in the media, which is a very complex, expensive treatment, largely been shown to be useful in leukemia, relapsed leukemia and things like that. And there's a lot of interest in that in other tumours at the moment. The way it works is you've got to have something on the tumour or in the tumour that you can design an antibody to and then stimulate things. And other cancers are often very heterogeneous. They're all different, and so it's hard to design something that will actually go reliably to a breast cancer in every patient. But that's a long way. I mean, the first CAR T cell patients in leukemia where it works have only been treated in Australia in the last few months, I think. And I think it's a long way before there's a trial in any sort of solid cancer, certainly in Australia. I think in the US it's about $500,000 a patient for that sort of thing.
Yeah, for sure. But with regard to the GPs, we have actually surveyed over 70 GPs who are looking after their patients around Australia to find out where the gaps are and what education we can actually provide and what they know. It was very interesting because the majority of them had actually known knew the patient pre-diagnosis, and I think it was 85 and 90% had not suspected a NET. So it was interesting to actually sort of get that documentation to see that. So as a result, we're looking at what we can put together as far as or triaging what's the most important information, and we're going to start rolling out next year education to GPs around each of the states, and we'll target the most important areas, but then build modules as well so that we can actually get more GPs aware of what NETs are. I mean, we all know that the symptoms are so vague. We did a forum in Sydney just for some GPs, and most of them said, never seen one. We said, well, you possibly have. You didn't diagnose it, and they went somewhere else. So there's a GP that contacted us, and she actually filled out a survey, and she was diagnosed with neuroendocrine not long ago. So she's a GP with neuroendocrine. She's only in her late 30s, and said that there was next to nothing when she went through med school. A little bit of carcinoid, but that was about it. So
I guess I just wanted to reinforce, you don't have to go to your GP to talk about how to manage a neuroendocrine tumour. Your GP is there to talk about all the other things, because the patient that Jane talked about who was angry with his cancer, I still look after him. That's 19 years ago with his metastatic NET. So he's got a lot of other health issues, and we oncologists and oncology nurses are not good at managing all your other health issues. And so you have to differentiate between going to your GP and asking about your NET treatment, but not ignoring all the other things, including the psychosocial issues that again we're not very good at doing in a busy clinic. The nurses in daycare aren't going to necessarily have the privacy to talk to you about all of those things. So it's actually looking after all of the rest of you that I'm more interested in the GP. And then that depends on how good relationship you have with your GP. We have a lot of people who have symptoms who don't go and see their GP, and they wait 3 months and come back and see us, and they've had the symptoms for 2 months. And so, well, I was coming back to see you, but it may be unrelated to their NET. So it's dealing with all the other things that go on around, I think.
Yes. I've got an interesting question here that was sent through. I read an article in an English magazine by Dr. Melanie Wynne-Jones stating that research had shown that aspirin might help protect against different type of cancer, including small intestine neuroendocrine tumours. What are your thoughts? David?
Well, I just came from HOTG. There's an Australian trial looking at aspirin as a preventative for colon cancer, where there's some epidemiological suggestion that may be useful. So there's currently a trial going on in Australia internationally using an aspirin post bowel cancer to see if it prevents you developing polyps and things. I must say there may be some preclinical work in small intestinal NETs, but I've not seen that. But most of that aspirin work is about preventing
Yeah.
changes within the bowel. So usually that's, you've had a polyp removed, trying to stop you getting new ones. That's the theory in these trials. I think if you've got an established small intestinal net that's already spread, then it's unlikely to be useful in that setting.
Can I ask another question? Because I'm you and I'm cheeky and I can. Actually, I've got two questions. So I wanted to pass the microphone down the line and swing past the oncologist/endocrinologists and then head to Louisa. So the first question on the way past is, we know that somatostatin analogues can reduce the pancreatic enzyme production. I hear from women who talk about their periods going wonky when they start somatostatin analogues. Have we got any knowledge or evidence around your menstrual cycles being affected by those drugs? And then on the way, when we've finished answering that question, sorry, I'm being really cheeky, Louisa, can we say anything about the financial toxicity study findings?
Yeah, sure, we can.
Great. Okay, this way.
First release.
I would say that anything can make your periods go wonky. Being sick can make your periods go wonky. Stress, there's periods going wonky is a very common thing. I'm not aware of, the somatostatin analogues definitely can affect pituitary hormones. We know that thyroid hormone, for example, is different. David has a patient who has to change his dose of thyroxine based on whether he's on or off the somatostatin analogue. So if the pituitary gland has somatostatin receptors, it is certainly possible that when you're on the somatostatin analogue, that does something to your LH and FSH, which are the governing hormones that drive your periods. And so it's certainly possible. I have to say it's not something that people have reported to me, but women may not think to report that. I haven't heard that before, but I think it's certainly plausible physiologically.
Thank you. A bit of a hitchhiker to this panel, but I'm a health economist and I work at QI Marburg Hopper across the road. And as David said, we today just finished a study on the financial burden of patients with NETs. And it was an online survey, and we had help with Kate and Simone and David and other collaborators around the country. And our findings are with the reviewers or with the journal at the moment, but we can share some early results. And so we had 200 responders. That was really great. The average age was about 59. And the purpose of the study was to try and understand the financial burden, because we know our health system is very complex and there's a lot of issues and a lot of appointments and doctors to visit, and these costs can really add up. And so we wanted to find out, what was the experiences of patients with NETs. And we asked questions about their medical out-of-pocket expenses, their non-medical out-of-pocket expenses. We asked questions about their private health insurance experiences, their financial household well-being, their quality of life. And we found some really interesting results. So there was a very wide range of responses with regards to the out-of-pocket expenses. So we had patients, over a 4-year period saying that they had just a few $100s in out-of-pocket expenses, and others, over $20,000. And this was data from Medicare. So we actually asked the responders to release their Medicare details to us, and so this information comes from Medicare. So it includes all the tests and services plus all the pharmacotherapies. So a very, very wide range, and the average was around $6,000 over 4 years. So clearly some people do have very high expenses. You will have higher expenses if you have private health insurance, because you'll have gap payments generally. If you're more seen in the public system, you'll have lower expenses. I think we're really lucky in Australia, different to other countries, because some of the therapies are only available in the public system. So the PRRT is through the nuclear medicine departments are available in public. The patient doesn't pay, so we're very lucky that doesn't happen in other areas around the world. And one of the main findings we found was that with employment, a lot of patients that were still in the working age, the midlife sort of prime of their working careers, felt that they had to retire early with the diagnosis. So this is a really, important problem for some people, because they may not want to retire, but they feel they have to because it's a metastatic disease, or because their symptoms are so bad that they can't continue with their work. But then it's a double whammy, because if they've also got high expenses and they can't work, then that can be a very big financial burden to patients. So the employment issue was very interesting and something we want to emphasise with the study. I guess the message is that if you are experiencing difficulty paying bills and you have that financial strain, is that there is help and you should ask for it. Places like the Cancer Council Queensland here, they have financial services, they have advisors, there's counsellors now that can point you in the right direction. You can ask your bank to give you a holiday on your mortgage. All these sorts of things are out there, but you do need to ask for that help. We know if you have financial strain, you're going to have lower quality of life, and that can be a real problem if it's affecting whether you're going to access your appointments, if you're going to delay treatment, if you're going to take one pill every 2 days instead of every day. I mean, people are doing this because they want to stretch their money. So, I guess the message is ask for help and talk to your doctor if you are experiencing these sorts of problems.
Can I make a comment about that? Absolutely, it is critically important, and appearances can be deceptive. I have patients in their 50s who, I've got one patient who's got a mortgage of $750,000. It makes me break out in a cold sweat. Increasingly, we're hearing that people in their 60s still have mortgages. So we shouldn't make assumptions. There is compelling data that if you have financial strain, you are 3 times more likely to become depressed. So this is not trivial, and once you become depressed, it undermines your ability to cope with symptoms, disease burden, it reduces your motivation, reduces your ability to engage in pleasurable activity. So there are cascading losses that accrue on the basis of this, so it's critically important.
Yes, this is called medical tourism, and,
Yes.
it's an interesting thing, because if the treatment's not available in Australia, there's usually a reason for it. It's not proven. Just because there's a treatment overseas doesn't mean it's actually going to work, and it's been through the evidence of the trial. So you have to be very wary about that sort of thing. I think there are cases of patients that travel interstate to get cheaper, public health hospital treatments. Like you hear people from Sydney that have private health insurance, but they decide to go to Peter Mac where it's all free, things like that, because it's cheaper to pay the airfare than it is to pay out-of-pocket costs. Things like that are not, obviously ideal in our health system. And as a health economist, I'm pretty concerned about these deficiencies with our the market for private health insurance, and how it just doesn't really.
Yeah, so there has been a change, but it's probably not relevant, to your case, unfortunately. So within about the last year, there is actually a Medicare item number for a DotaTAC PET scan, but really it only would apply in general to perhaps once in a patient's history. So generally it's a diagnosis. It really applies to if someone's been considered for surgery. So it's really that initial staging scan, or in some circumstances, if there's sort of hormonal levels that are increasing but they can't identify where it's from. But in general, for most of the patients, certainly the patients who are on PRT, it doesn't really apply at all. And so for other NET patients, it's it applies to some, but a minority, and not for ongoing monitoring. There are some rebates at some hospitals through one of the drug companies that helps to support the scans, so for some patients, so that can reduce the cost. And then for patients, certainly for all patients who are directly managed at the Royal Brisbane, all of the PET scans that we do for patients from the Royal Brisbane or from other sort of affiliated hospitals are all free of charge. Yeah.
Thanks. I'm really sorry to have to cut it short, but we are on time restrictions. So I'd like everybody to say thank you to the panel so much for